Um,
Great, thank you very much. So I think we'll open this up for the panel now. Thank you very much, Dr. Sethi. That was fantastic. So there are some questions in the chat. I just want to check that Dr. Oliver's here too. Yes. So maybe I'll start just with Dr. Folman and Dr. Oliver, and then we can get to your questions in the chat, Dr. Sethi. So because I think, sort of we started with the antibody responses through the vaccine responses and sort of ended up with the adaptive T cell prolonged responses, which was sort of, which is definitely important for us ongoing here. So Dr. Folman, just going back to your talk, you mentioned at the beginning that the immunity that you're seeing, which I'm assuming is antibody immunity, is only 6 months to seasonal coronavirus. And obviously we're not seeing the antibody immunity being terribly durable, like maybe 8+ months for the SARS-CoV-2 vaccine. So is there anything, different about seasonal coronavirus compared to some of the other respiratory viruses like flu, or do we think they're all the same at this sort of limited antibody response? And is there any way to improve on this, or is it just more about getting different mutant strain vaccines out every year like we do with the flu? Do we have any idea about that?
Yeah, I would defer to Dr. Sethi, I think, for comparative immunology for the different respiratory viruses. I've focused more on SARS-CoV-2 and so on. Go on.
Sorry, with the seasonal coronavirus, do you have a sense from that?
I would refer to Dr. Sethi for that as well. I've worked with Arnold Monto a bit, and we've tried to correlate antibody level at the start or end of a season for seasonal coronaviruses, and they didn't seem to correlate very well with acquisition of seasonal coronaviruses. It could be that the sample size was too small, or who knows what, but we didn't show much of a correlation there. I think Dr. Sethi's point about T-cell immunity being a more major player now that we're all becoming antigenically experienced is really on point. And one thing I really like this talk, and one thing I'm imagining is we're going to be doing correlates analysis for the warp speed trials where immunity antibodies have waned, they've been boosted and whatnot. And I don't know if that curve that I showed earlier will be present when we do it in the future. And so I'd like to measure T cells, but that ship has sailed for the warp speed trial. So I don't know. That's sort of I think where I'm sitting right now.
I guess the other question I have for you is, there's a lot of anecdotal reports out there about people saying, oh, well, for my fourth booster, or my second booster, my fourth shot, I'm going to switch it up and go to a different brand. So, i.e., if I did Pfizer for 3, I'm going to do Moderna for 1. Have you noted, is there in your cohorts, is there any data, or is it all, everyone's just getting the same?
Yeah, for the warp speed cohorts, they tend to get the same vaccine, and that's sort of by design to do it. I think it's a quite fair question to ask whether a different vaccine might broaden or be different in some way, but I don't know of data on that directly just yet. The COBAL study I alluded to is going to be looking at that, where there'll be different flavors of the first 3 doses and then something else. And so we'll learn about that and continue to learn more, but nothing really to take home right now.
Great, thank you. So Dr. Oliver, so maybe have you got a sense about, I know there's not so many children that have been vaccinated, but do we have a sense about how long the antibody immunity is lasting in those children that are vaccinated? Because are we concerned that it could be shorter even than in the adults, or do we not know that data?
So ultimately, especially if we look at 5 through 11, we don't have as much time since they were only recommended back in November. And it's difficult to do the studies when it's a small proportion. But I will say places where we've been able to kind of overlay, we've seen that the 5 through 11 are really mirroring almost exactly what you see in 12 to 17 and in adults. So we see kind of that, especially if you look at infection, protection against infection, where we get that Goldilocks time right after vaccination, where it looks like protection is really good, and then it really seems to kind of drop off at a really similar rate. What I think will be interesting is we know the best protection is actually natural infection plus vaccination, and so as we think through the population of kids who potentially, had COVID and get vaccination, it could be that we see that the children who are more likely to have had COVID at some point in the past actually do have some better protection because they may be more likely to have hybrid immunity than potentially some adults. But I think we'll need a little bit more time and a little bit more numbers to fully understand that.
Great. No, I think that's really important, so that we will watch that space for sure. So, Alex, there's a few questions for you in the Q&A. So one is from Gigi Notarangelo, who asked, did the study of patients who were infected with SARS-CoV-2 and were unable to produce specific antibodies inform on which T-cell epitopes may be more important targets to be included in next generation vaccines? Like, did you see?
That's a good question. I think it has not been done very extensively in comparing the repertoire of people that do not make antibodies versus normal ones. I think as a superficial impression is that the repertoire is not that different. Certainly people that are infected make a lot of T-cell responses against N and also against NSP. There is very interesting data coming from Maini's lab in the UK and Bertoletti that implied NSP12, for example, as really having a very important role. In that case, actually, they had healthcare workers that had high level of pre-existing NSP12, and they seem to have actually abortive infection, even they don't even turn seropositive. And one of the things that also has to do with some of the NSP proteins that are highly conserved across different coronaviruses and other sarbecoviruses. So that's why a lot of people, including us, are interested to see if they could be a useful variant-proof addition to obviously the spike. Nobody is going to go away from spike, but to add to spike, make a spike plus may be a good way to go.
Great. And then there's another one. Do you see differences in expansion of SARS-CoV-2 reactive CD4 versus CD8 T cells following infection versus vaccination? For example, do CD8 T cells expand more? But I think your data showed that CD4s expand more, but maybe I was wrong on that one.
Well, yes. So I think that there are two parts to this question, if you wish. One is, are there more CD4 than CD8? And certainly that has been the common experience that it's harder to see CD8 responses against SARS-CoV-2. So whether that is our problem in the sense that we are less capable of detecting them, or they may be more resident in the respiratory tract or not, that remains to be debated. But certainly has been much easier to see CD4 T cell responses than CD8 response. The second question, is that different in natural infection or vaccination? And my impression is no, it's the same thing. It's not that vaccination versus natural infection have table turn in terms of a ratio of CD4 antigen specific CD4 CD8.
Correct. Right. Yes. No. And so then there's another question. It might be for Dr. Oliver. What was the cause of the earlier side effects seen with vaccinations in the young males, in particular the myocarditis and transverse myelitis? Can anyone answer that?
I'm happy to weigh in on what we know, and then if others want to weigh in. So I will clarify, we've not had transverse myelitis as an issue with the vaccine. There was, I think that may be referencing, there was one case in the AstraZeneca trial, so it was briefly paused while they looked into it. She was ultimately diagnosed with multiple sclerosis that was completely unrelated. They've not seen it in any post-authorization surveillance. So I think that was just an unfortunate trial participant that didn't seem to have anything to do with the vaccine. For the advector vaccine, so the two safety issues, or the two main safety issues that we've addressed are we call it TTS, the thrombosis with thrombocytopenia syndrome that's seen after the advector vaccine, so the Janssen vaccine in the US, that has actually led to us having a preferential recommendation for the mRNA vaccines. I'm happy to share, but there's kind of a variety of CDC presentations that walk through really what that is. But that appears to be hit-like, where they're having kind of anti-PF4 antibodies that's resulting in unfortunate blood clots that can be in these major venous areas. Then the myocarditis is kind of very different, and we have seen that in more male teens to young adults, which is just where myocarditis tends to happen in general. And this appears to be relatively mild and relatively self-limited. So we've seen it, it's rare, but it happens. And again, in this population, we're talking about as low as 40, maybe as high as kind of 70 per million. So again, rare. We know that the rates of cardiac complications after COVID infection are about 6 times higher than what we see with the vaccination. So the best thing to do to protect your heart is still get the vaccine. But we do acknowledge that is something that's been seen with the vaccine. But as we've followed long term, there's these cohort studies going on in the at CDC, and everybody so far seems to have resolved that it's self-limited, and as you kind of follow out over time, their symptoms resolve.
Great, thank you so much. So